Welcome to the Power of One. Today, I am going to be speaking with Dr. Sean, and we're going to focus on pediatric health today, which I think is extremely important. Welcome to the show, Dr. Sean. Dr. Ciullo, please tell the viewers all about your medical background and your current medical positions.
Sure. Hi. I am a pediatric general surgeon, and so my background means that I had 4 years of medical school after going to college, and then 7 years of adult general surgery training. 2 of those years were doing research, and the other 5 were clinical, and then 2 years of pediatric surgical training, which I did here at St. Christopher's. So a long time. And then I worked here for several years as an attending surgeon. I left for several years, and just returned back in December. And I am a pediatric general surgeon, so I do all types of surgery in the kind of middle part of the patient. So like from kind of neck to legs, but we do all kinds of different surgery, including trauma. And I'm the trauma medical director for St. Christopher's. So I run and organize the trauma program here. But all of us as pediatric general surgeons help take care of trauma patients.
Now, the trauma program medical director, what does a day look like for you?
Yeah, so I work with a group in our trauma department. So we have a trauma manager who's a nurse. We have uh, project improvement and quality people who work in the department as well, injury prevention folks, registrars who are responsible for taking all of the information about our trauma patients and putting them into a registry for research purposes and to report back to the state. So I meet with them on a regular basis to see what needs there are. I have meetings with our administration about different things going on in our program, and not all of those every day, but a variety of meetings related. And we have monthly meetings with all of the other departments who help take care of trauma. So our ICU doctors, our ED doctors, the nursing staff, physical therapy, et cetera. And a part of my job is just kind of coordinating between all of those people to make sure that the system works well for all of our patients.
I can imagine it is a task to maintain a lot of healthcare professionals. How do you ensure that the necessary bylaws, and I don't know if that's correct, or the standards are upheld? Now, are there standards and bylaws that need to be upheld on the hospital side, but also like on the state side?
Yeah, so there are for both of those things. So for the state, we are accredited as a level 1 trauma center, which is the highest level of trauma center. So we can see the most complex patients here at St. Christopher's. So that is something that we are visited every few years by the state to have a survey to look to make sure that we're following all the protocols and procedures that um, are in place through the Pennsylvania Trauma Society Foundation, PTSF. So they come every few years to check on us. And then we also have our own policies and protocols in place regarding the care of trauma patients. So if a patient comes in with a certain type of injury, there are certain pathways that should be followed in their care. And so that's a big part of my job and the department's job is to look at all of our trauma patients and make sure that all of the pieces are working the way that they should and that we are providing the care that we're supposed to. Which I'm happy to say for the most part is true. And when something changes, we look to say, is that something that's reasonable to have changed because of a certain circumstance of this patient, or is it something that we need to improve upon? And we're always looking to do a better job for everyone. And so that's part of my goal is to interface with all of the providers who help take care of our patients to make sure that everything is going as best as it can.
Now, speak about patient safety and satisfaction. I don't know if that's the right word, but I know it's so important to make sure that patients are safe when they come into the hospital and they're having procedures done. And mind you, we're talking about babies. So you and your staff are dealing with babies, not only the babies, but but the parents. So if they're anything like me, like my dad, he's a senior, but when my dad was diagnosed with heart failure, it was hard for me to believe. And the doctor would come in and he's talking, and I'm interrupting the doctor like every 2 seconds. Like, is it okay? Is that treatable? Is it curable? Is it treatable? Is it curable? And I think I kept saying, is it treatable? No, curable. And then the doctor was kept saying it's treatable. Like, okay, ma'am, stop interrupting me. So I guess you guys deal with it on both levels. So you have the babies.
Yeah.
The babies can range from 0 to probably 21, and then you have the parents. So speak about the safety side of it and making sure that the parents and the children are satisfied with the level of care.
Yeah, there are, I feel like so many things I could talk about to answer this question. I'll try to pick a couple. So one, for safety, like there are lots of good policies in place about, making sure we're taking care of the right patient, because as you're talking about, babies can't tell you I'm
Mm-hmm.
Smith, right? Like, so knowing that they have a name band, asking the family, is this patient? Those sorts of things are all in place to be safe. There's all of the standard sort of hospital things that all hospitals have about making sure that medications are administered to the right patient and procedures are done the right way. All of that sort of stuff is not, I would say, unique to St. Chris, or any hospital. It's kind of universal. But I think you hit on something really important in, having your parents are also a big factor in this. And I think a lot of people who are interested in working in pediatrics may love working with kids, and then they get in their training to dealing with an adult parent and are like, oh no, this is not what I was signed up for. But as you were talking about, it's the same thing when you're dealing with an older person and their child. The roles are reversed,
Mm-hmm.
but you do have to, I think it takes a special kind of person to work in pediatrics and be able to interface with parents who are understandably very anxious about what's going on with their child. And you need to take time, especially not just for the babies, but for the older kids who can understand what's going on, to have a conversation with them as well as their parents. And you have to be able to talk at different levels for different people's levels of understanding. And then another thing I wanted to hit on here in terms of being safe and secure is that we have a whole child life team here, and their whole job is to help families and patients specifically with the challenges and stresses of being hospitalized, having an IV, getting a blood draw, going to an X-ray, things like that. They work through all of those things with the kids, so that, and also the parents, but with the kids, to make sure that they are supported and know what to expect and aren't frightened by things. And they do a really wonderful job of that, which I think is related to the question you're asking.
That's awesome. That's awesome. So you are also a assistant professor of surgery and pediatrics. So tell the viewers what that means. Does that mean you like what that job entails, research, and do you have publications?
So the job here at St. Christopher's is in what's called an academic surgical position. So that means that I am responsible for teaching as well as operating. So in my last job, when I went away from St. Christopher's for a little while, I still did a little bit of teaching, but it was a non-academic role. So I didn't have a professor title. And it doesn't really change anything about me or what I do, but here we have pediatric surgery fellow, who is someone who will become, just like me, another pediatric surgeon. But we also train adult general surgery residents who are learning how to do adult surgery, but also have to have some pediatric exposure. We also train NP and PA students as well as medical students, and also interface with all of the other educational groups in St. Christopher's. So our neonatology fellows, our pediatrics residents, the ED fellows, all of those places have learners who need to know things about surgery that I am here to teach them. So that's a big part of the job. And then also, um, related to publications. So I do research through our department. We have a research fellow who helps with that. And so we're looking at, for me, because I already work with trauma, that's where most of my research is at the moment. And so we're looking at different uses, like we use a certain type of blood transfusion here that isn't used everywhere. And I don't want to get too into the technical details because it's boring, but looking at what our experience has been here, because we're one of the places who's been doing it the longest. And then looking more deeply into that, into like how certain things about that change a patient as they go forward if they've received a blood transfusion. And also just other types of research. In my last job, I was doing research on, do you know those little water beads, Orbeez, the things that like they're little round beads, you put them in water, they get swollen. Some kids
Hmm.
eaten those and caused a bowel obstruction because they get
Oh,
swollen
wow.
inside their intestines and can cause a blockage. And we were working on ways to try to treat that without doing surgery by having them drink something that actually kind of pulls the water back out of the bead so it's small enough to
Yeah.
belong. So I have a couple of recent publications related to that, and a prior publication looking at how our adult ED colleagues take care of pediatric patients and how we as pediatric specialists can help them be more comfortable taking care of certain things going forward. So that's an outreach education thing that I'm working on currently.
Okay. What does patient advocacy and outreach look like for you?
So we, I think, are in a really great position to do those things here at St. Christopher's. I'm very happy to be talking to you as someone who does patient advocacy far more than I do. But I am always an advocate for my patients, and I fight for them to get the best care possible and make sure that they have the appropriate resources when they're going home. I actually would love to be more formally involved in patient advocacy going forward. I am working on trying to find the right venues, including talking with you. And then outreach, I kind of touched on the last question. A lot of my outreach goes to our pediatric and adult providers in the community in helping them and supporting them, educating them in how to take care of patients who might have a surgical or trauma need, and helping St. Christopher's be seen as that great resource for all of the community to use. So we go out to pediatrics offices and I give them my cell phone number so people can call me and send me pictures of lumps and bumps that they have in their patients and be like, what do I do with this? Is this something I should be worried about? Should I send them to see you? Try to help in those ways as well.
Well, that sounds good. I'll get your number offline. So when I'm freaking out about something on a weekend, Doc, what is this? Tell me what this looks like, and we'll talk offline about that. So you teach a lot of healthcare professionals. Let's talk about bedside manner, which I think is so important. And I think it's important for everyone, no matter what race, no matter where they come from. Speak about bedside manner and how you teach those under you about bedside manner.
Absolutely. I really love that aspect of teaching, and as much as I teach other medical learners, I love teaching families about the things that are going on as well. And I think everybody, you have to kind of tailor what you're talking about to the level of understanding, again, like talking to a child, talking to an adult, someone with medical backgrounds and not. But I think it's really sometimes overwhelming when a bunch of people walk into a room and you're laying in a bed and you're a parent right next to that and you're scared and don't know what's going on. And I try to work to talk to them first, and then we'll maybe have a conversation with my learners as well about something. But I try to make the family the priority. And then oftentimes the discussions that I can teach the residents and fellows can happen just outside the room after we've, everybody's seen what's going on, and then we can talk about it later so that it's not quite so intense for everybody there. But I love talking to the families about things, and it's something that, and you're talking about when your father was ill. My grandmother was sick and in the hospital when I was a medical student, and I would go visit, and I would say, "Well, what did the doctor say today?" And she said, "Oh, I don't know. I didn't really understand." And I said,
Mm-hmm.
well, what do you mean you didn't understand? And she said, well, he said some stuff, but I didn't really know what he meant. I said, why didn't you ask what was going on? Why didn't you ask for him to explain it more? And she said, oh, I'm sure he was busy. I didn't want to bother him. And I wish I could go to like every person and tell them that for themselves, for their parents, for their children, that like that's my whole job is to make sure that you as a patient or a family member know what's going on. And
Mm-hmm.
if there's a true emergency and I have to go, I will come back. But otherwise, I need to take that time to explain things to you, or I'm not doing my job well. And so I really think it's so important for people to feel like they can ask questions, and to say if the answer doesn't make sense, that I'm sorry, I still don't understand. Can you try again? Um, and I want to take that time to help find a way to make that connection. And if it's drawing pictures on a board in the room, if it's showing you like a website so that you can look at something on your own with at your own pace, whatever it may take, I really want the families to be comfortable with what's going on. I hope that answers some of your question.
You did. And you made me think about something else when you were speaking. And when my dad was in the hospital, so my dad was in Abington,
Mhm.
Jefferson Hospital. They do an amazing job. I love them. I actually sit on two boards. My mom sits on two boards. My daddy sits on one. But I never understood, and maybe you can bring some clarity to me and to the viewers. Why do the doctors come so early? And like you said, with mom, it's just mom in there. I always think it's good to have a second set of ears when the doctors are in there. So explain to me and the viewers why the doctors come so early, and why don't necessarily say, is there a family member maybe you can call, or a family member, I'll come back when a family member is up here so I can talk to both of you at the same time.
Absolutely. So for surgery, at least, the origin of the really early rounds is because generally the operating room starts at about 7:30, and the residents here, or if I was by myself, like operating perhaps all day, the only guaranteed time I'm going to have to run and see everybody who's in the hospital is that early time in the morning before the
Mm,
rest of the day gets started. It's definitely
okay.
not ideal, but there are gaps in between surgeries as things are getting turned around and getting ready again. And we do have some time in there, and I'll try to run up and see people in between then as well. But the residents are expected to see everybody before I get here. And so it gets like earlier and earlier and early, like so they are oftentimes seeing people depending on how many people they have to see at like 6 in the morning. But normally now I feel like the attending surgeon, the person in charge of the team, comes not normally quite as early. Um,
Okay.
and but it's always hit or miss uh, in terms of what family is present for us, and
Right.
I'm sure in the adult world too, because maybe you're the child of a parent who's in the hospital and you have to work until 5 o'clock. Well,
Hmm.
after 5 o'clock, if I'm not the person on call, I may be home. And so
Right.
I do agree that like trying to call people on the phone is very helpful as well. And I also will do sometimes FaceTime, and I'll have one parent in the room and they're like, hold on, I'm going to call, my wife. They're at home because the other kids are at home. And so I think asking the family on our side, asking family, is there someone else that you want to involve in this conversation, is something that we could probably do better.
Mm. Okay. Okay. Now you were speaking about fellows, residents, medical students. Break that down for us. What's the difference?
Absolutely. So medical students are trainees who are still learning to become doctors. They've had high school and college educations and now are in their training to get their medical degree. And so they haven't necessarily picked a specialty yet. They don't know necessarily if they are going to do pediatrics or psychiatry or emergency medicine, surgery. And so they have required rotations clinically to see all the different major specialty groups. So on their surgery rotation, they may be working here in pediatric surgery, or they might be on a vascular surgery service in an adult hospital, or trauma surgery someplace else, et cetera. So, it's all broken up, and they have to have, a few weeks of this and a few weeks of that. So those are medical students. After you complete your medical training and you have your medical degree, you then go on to your residency, which is the training in that specific specialty. So for me, my residency was in adult general surgery. People can do residencies in pediatric psychiatry, orthopedic surgery, the list goes on and on. And so that's kind of your general training in a specific field. And then people can finish that and go to be, an adult general surgeon or a general pediatrician who would be seeing patients in the office or et cetera. Or they could subspecialize. And then normally the additional training and a very small thing after the general training is called a fellowship. And so for me, it was a pediatric surgery fellowship, which I did here for an additional 2 years. And so in our emergency department, people who have done pediatrics will then do 3 years of pediatric emergency medicine, or in the neonatal ICU, taking care of the tiny babies, they'll do 3 years of that. And so that's where a fellow comes. But all of the things just have different levels of hierarchy in the training years and years and years that people go through.
Okay. So you said earlier that you perform surgery from it,
Yeah,
the
the,
chest
the
up.
middle parts.
What's the proper name for that?
uh, I don't know. I don't think there's an all-encompassing term. And what part of general surgery is that we do a little bit of everything, but I would say that the major two areas are the thorax, which is the chest, and the abdomen. So those are the two places that we do most of our things, but I'll also do some neck surgery, and sometimes even little things on like eyebrows or on a limb and things like that. But generally things that are not covered by another specialty. So I have family and friends who are like, my ankle hurts. Can you tell me what's wrong with that? I'm like, no, I don't do bones. Like I'm a general surgeon, which means like all the
Right.
other stuff, but I don't do bones, I don't do brains, I don't do hearts, or urology things. Like those are all, or ENT. There's some overlap in those places, but those are normally their own things. Yes, people really want me to tell them why their back hurts or their shoulder hurts, and I'm like, I'm sorry, that's not really my thing. But yeah, so general surgeons is mostly the mid part of the body, excluding the heart. But I do surgery on intestines, on lungs, hernias, appendixes, gallbladders, livers, cancer cases, all sorts of different things in my role as a pediatric general surgeon.
St. Chris is located in one of the highest crime areas in the city of Philadelphia. Do you and your team treat those who are affected by gun violence, youth who are affected by gun violence?
Absolutely. We take care of a lot of those patients. And in fact, I was on call this weekend and I was here from midnight to 2 taking care of two gunshot patients last night.
Mm.
They were both fine. Everything is good. But yes, we do see a fair number of patients who are victims of violent crime here at St. Christopher's, more so than I think a lot of other pediatric hospitals that are not located in places
Mhm,
like this.
mhm. Does that bother you at all? Or like, how do you take care of you? Like, I can't, like, when I'm dealing with cases with the babies, that gets to me. And people ask me, how do you just keep going? And how do you do this day after day? Sometimes, I mean, burnout is real. And you look at your family because some of the stuff actually touches your heart. But the babies, how do you do that? And how do you stay refreshed? And what do you do for self-care?
I don't feel that refreshed today, but I I think that it bothers me in the sense that I wish that that was not the reality that our patients live and that that wasn't how things were. And I hope that in times things will change and with better, hopefully with better laws and advocacy and things, and there may be less gun violence. But in the immediate time, I'm glad to be here to help.
Mm.
It is hard. It's important, I feel, to remember all the good that you're doing to help these people, and that helps me.
Mhm.
It's also helpful to have a good support system at home, but also my
Mhm.
partners here at work, where I could have a crazy weekend and I can come in today and see my partners and sit down in their office and be like, oh boy, can I talk about
Mm.
all the things that
Yeah.
happened? Because my family doesn't necessarily have a medical background,
Mhm.
but
Mhm.
it's great to talk to them about some stuff. But it's also great to have other people who are truly living what you're living be able to talk about it and know that they're also at times struggling with these things. But yes, the babies are hard, but it's hard at all times. In
Yeah.
adult trauma and our teenage traumas. It's all um, upsetting, but I know that we're giving them good care and that I'm helping them in the best way that I can.
I
And
thank you so much.
oh, well, thank you. And then in terms of self-care, you're asking about, I love, right now I have a 2-year-old daughter, so I don't have a lot of free time, but some of my self-care is just getting to spend time with her. I
Oh.
got home last night just in time for her to go to bed, and I got some snuggles and listened to a couple songs and stuff,
Oh.
and that was great. But also I like to cook and bake, and I used to do in my last job, I had a little more free time. I did some pottery that I'd love to get back into, but haven't had time yet. But things like that, just, the occasional little thing to have a break and not think too hard.
Well, the Northwest Victim Services office is located at 6023 Germantown Avenue, so it is not too far from St. Chris.
Uh-huh.
So when you're baking and you're cooking,
Okay.
I love to eat.
I'll
So
bring
I
something
think
back.
this is going to be a great collaboration, Doc. So I think we
Absolutely.
can help each other in one way or another. But thank you so much for joining me today. I thank you for everything that you're doing for all of the babies. Now, babies for me could be again 0 to, well, I have a 30-year-old baby. I have a 28-year-old baby. So once they're your babies, they're always your
You're
babies.
always your baby.
Well, thank you so much for all that you do.
Thank you. It's my pleasure. I really appreciate being here, and I appreciate all that you do for our patients as well. Thank you.
Dr. Shawn, thank you so much for joining me today. I hope all the viewers gain some great knowledge. It is so important to keep up on your child's medical health. Peace and love.